Okay, so it's a pleasure to be here again, and congratulations to the organizing team for again a wonderful workshop, and pleasure to be with the master of the masters, Professor Palazzo. So this lady, she is 45-year-old lady who has presented with epigastric pain, and on investigations it was found that her LFT lipase biochemistry is normal, and on imaging she was found to have a cystic lesion. The CT scan was done, which showed a cystic lesion in the peripancreatic area, and there were calcification in this area. So now over to Dr. Palazzo. He will demonstrate us what we found in this case.
Okay, so you hear that this lady has a huge cyst into the tail, at the level of the tail of the pancreas, in the area of the tail of the pancreas, with calcification. When you hear calcification on the wall and the septa, they have septation in CT. She has no MR, she has CT. When you have calcification in the septation and the wall of the cyst, you know that it's not a usual cyst.
It's chronic.
It's a chronic cyst. By definition. Sorry?
They want to cursor to show the thing. We are not yet there. They want to see the cyst.
Okay, no, I discussed before to show you the cyst. I'm sorry, but I am directing what I'm doing. Because if you don't do like this, you are wrong. So when you hear a chronic cyst and
calcification,
because of calcification, immediately you have to think this cyst is not the cause of the pain. You have to imagine that the lady has crisis for another reason. Because if it's the cyst which is given crisis, she has crisis since 10 years and not since some months. Okay? And it's the reason why when I start the exam, I look immediately to the gallbladder before looking at the cyst.
So this is the gallbladder.
And as you see, this lady has gallbladder stones. Okay? This is the first thing. Now we will move to the cyst. So she has fatty liver. And now we move to the cyst and we look at the pancreas. And you see immediately that the pancreas which is there is normal. Okay? This is the patient wake up. This is a normal pancreas. Okay? Here you have the portal vein, the mesenteric vein, the splenic vein. The duct is very thin. And yes, the duct is seen, and now we move back to the tail, and you start to see the lesion.
The lesion, yeah. There's a cystic area.
And this lesion is close to the spleen. It could be coming from the spleen. It's close to the pancreas. It could be coming from the pancreas.
It's kidney.
It's close to the kidney. Here, it could be coming from the kidney. So finally, you have a huge cyst with calcification of the wall. You see the calcification of the septa? You see these bright things? Okay? And here you see all this calcification. You see? So you have a huge cyst which is 10 centimeter 8. We have a measurement before, 10 centimeter. And we don't know really if it's coming from the pancreas or another organ or the retroperitoneum. Okay? So this cyst could be, you have some ideas, big calcified cyst at the level of the tail and the body of the pancreas. You can think to a mucinous cystadenoma, but an old mucinous cystadenoma. So a dangerous mucinous cystadenoma. And because it's more than 8 centimeter or more than 4 centimeter, 8 centimeter, if it's a cystadenoma, there is a high risk for high-grade dysplasia at least, and malignancy perhaps, because it's more than 8. It could be a retroperitoneal cyst, calcified retroperitoneal cyst. It could be cystic calcified lymphangioma. It's not an IPMN, since IPMN 10 centimeter without any abnormality of the main pancreatic duct
not
and
so
of the
common.
pancreas, it's not common
Yeah,
at
yeah.
all. Okay?
So what should we be doing, Professor, now? I think should
So
we
I think that the only thing we can do, but perhaps it does not give us the answer, it's an EUS guided FNA, not FNB. FNB, you do FNB when you have a target to FNB. You do FNA when it's like this. You have no target. You have a cyst. You have no nodule. You have no mass.
and what needle?
Is there any communication with
No
the
No communication.
communication. No communication
That,
at all.
that's very important. That's very important point.
sonographic like features? Would you rely completely on it, like if there is septation or no? Because it says unilocular.
Uh,
So do you usually see septation to say it's mucinous, or it can be unilocular and still mucinous?
So
These are the
this
septations.
this septation could be mucinous cystadenoma, not IPMN. When you have calcified septations and calcified wall, you have to think to old mucinous cystadenoma if it's coming from the pancreas. Okay, if it's a pancreatic tumor, develop outside, but origin pancreas. So this is the main diagnosis and the only one of lesion at this area of the pancreas with calcification. But perhaps it's not coming from the pancreas. It's impossible to say. When it's closed to the pancreas, finally you cannot say, oh, it's coming or it's pushing the
Yeah.
pancreas.
Is it extrinsic or it's from intrinsic? Yeah,
Yes, you
we
cannot.
make out.
So
Yeah.
now we will do a FNA, and
Okay, okay.
perhaps
What needle?
What do you think about biopsying through the 19 gauge with the Murray biopsy or through this take a bunch from the wall itself? Would it help to differentiate?
no, because
The
no,
wall.
no, you have to know that in mucinous cystadenoma in general, when you operate mucinous cystadenoma, so more than 4 centimeter, 80% of the epithelium surface has disappeared. You know, 80%. When it's calcified, it's more. So the probability that when you put your moray, it gives something
Is very less.
is very less. So unfortunately, this case is very, very, very difficult. So with FNA, we will have the viscosity. If it's viscous, we know it's mucinous. We will have the color. If it's milky, it's a lymphangioma. And
Dr. Palacio,
yeah,
we'll probably shift to another room, but we'll see the color of the fluid. We'll go back to you later
Sure.
on to see the color of the fluid that you guys aspirated.
yes.
Sure.
For now we'll shift to another room.
Last thing, I use a FNA needle, not